All righty, so welcome everyone to the Cleft Palate Craniofacial Journal's video and audio podcast. I'm Pat Chibbaro. I'm your host, and you can see I'm wearing my Yankee regalia because our team has lost 8 of the last 10. So I don't usually get dressed up in this way, but just to let you know why I'm a little crazy right now. But thank you for joining us. And I wanted to talk with 2 of the authors of a paper that really caught my eye, and I don't mean that as a pun, but I was saying to them before I started that one of the things that I remember when I first started in craniofacial surgery as a nurse practitioner is walking into the PICU the day after a child, not right away, but maybe the next day or later in the next day, when a child had a cranial vault surgery and the swelling was just indescribable. And I realized that I really had to do a lot of preparation with the parents about it because it just is something that is extremely overwhelming. So I was really glad to see your paper, which is Eyeing Risks, a critical analysis of the use of periorbital steroids in frontoorbital advancement. And I first saw this online first, and I think it was March 28th. And so if you scroll down on online first, because we're not sure if it came out in the journal yet, but it may have, but we're not sure. But go down, scroll down, you'll see page 1, 2, 3, go to page 4, and you'll see it. And the authors are Doctors Daniel Cho, Jessica Blum, Nicole Kernick, Jordan Swanson, Srinivas Susarla, Jesse Taylor, Richard Hopper, Scott Bartlett, and Craig Bergfeld. Now, being in the field for all these years, I thought, well, that's quite a group. They're from University of Wisconsin, Children's Hospital Phoenix, Children's Hospital Philadelphia, and Seattle. And the first thing I always think is, wow, trying to do multi-center is really challenging. I want to ask you about that a little bit later, but I want to welcome Daniel and Jessica, who are nicely dressed in their professional uniforms. And just welcome and thanks for joining me.
Awesome. Thanks for having us.
So I always like to know, why did your group decide to study this, and how the heck did you do it together?
Yeah, so this is a project that I started when I was finishing up my residency. I had decided I was interested in craniofacial surgery, and during my pediatric and craniofacial rotation at Seattle Children's Hospital, I noticed that some of the kids who had frontorbital advancements, they seemed like they were less swollen, they seemed like they were going home faster, they seemed like they were less uncomfortable, and others weren't. And when I kind of anecdotally thought about which patients were which, I realized that the patients that I thought were having a smoother course postoperatively were the ones that had been getting Kenalog or a steroid soaked on gel foam that was placed underneath the scalp flap on top of the forehead during the surgery. And I was curious, is this actually better for our patients? And so I actually started doing the study comparing children who got the steroid through the gel foam versus versus patients who didn't. And when we started looking at the data, we were surprised to find that there were a number of bigger infections that did occur, which is something that we do worry about with steroid use. And the results were less profound than I was expecting. And then as I was continuing this project, I finished residency and I went to fellowship at the Children's Hospital of Philadelphia. And I realized that they had a slightly different protocol for administering the steroids. And they were using a tumescent solution that was injected around the eyes prior to surgery. And I thought it was a really interesting opportunity for us at 2 very high volume centers to look at the outcomes of 3 different techniques. And Jess was our research fellow at the time. And since I was really clinically busy, I asked her to help me kind of look through all the patients from Philadelphia and to kind of run an analysis across all the groups. And I think the really cool thing for me was that although it was at 2 different institutions, having operated with every attending who did cases for the study, the technique was very well preserved. One of our attendings from Seattle had trained in Philadelphia. One of the attendings in Philadelphia had trained in Seattle. So that cross-pollination really did conserve a technique that allowed for a reasonable comparison of the patients.
Right, right. Really, I saw this group and I thought, how in the heck did you guys, like, how did it come to be? And that's so interesting that you were able to sort of mesh this group together, and for you to have been in both places. I think that's pretty unusual, pretty, and just really, really interesting. So Jessica, you're a second year resident working with Daniel, correct?
Correct.
He's
Yeah.
He's a great guy. One of my favorites, definitely.
Couldn't agree more. The residents here all agree too. The awards on his wall are just the concrete proof. So I feel very blessed.
Well, so why don't you maybe give those listening an idea of, give us a little bit more about the study itself and some of the things you found, and then I had a couple of thoughts and questions for you guys.
Yeah, of course. So essentially, as Dr. Cho alluded to, this is a retrospective cohort study. We have essentially 3 cohorts, I think of it as 2 treatment cohorts and then 1 control. And so essentially, all of our patients, both at Seattle and at Children's Hospital of Philadelphia, who were undergoing frontal advancement, were assessed to see if they were eligible for inclusion. Our 3 cohorts were comprised of patients who received injection of the Kenalog periorbitally, as Dr. Cho said. There's a group that received direct administration of the Kenalog via gel foam soaked in Kenalog, placed over the bando. And then there was a group that didn't get any Kenalog that we call the non-group. And so those are our 3 groups. And we were looking at is there a dose-dependent relationship, and does the method of administration of the steroids impact postoperative complications, length of hospitalization, and with a special attention to infection risk. And what we found was pretty interesting. Essentially, we had over 400 patients in the cohort, and that dose-dependent relationship, our hypothesis was that the dosage of steroids would be associated with the risk of infection. And that did ring true in the sense of looking at the rate of infections. That highest concentration of Kenalog, which was given for the gel foam soaked Kenalog group, we had an infection rate of over 10% in that group. And then with the patients who received the injection or the tumescent administration of the triamcinolone, the rate was lower at 4.4%. And then for the patients who didn't get any Kenalog, we had an infectious rate of 2.6%. And so we found that to be very interesting. And it was fun to postulate what is contributing to that higher rate of infections in the patients who are getting that gel foam soaked, Kenalog soaked gel foam. But it was, it's something that I'll let Dr. Cho talk about more, but has definitely impacted practice as well. So
Daniel, I was thinking, when you think about infection rates, there's all these different variables, and what things could cause the infection. I thought it was interesting that you mentioned the gel foam. The first thing I thought about was, that's a foreign body, so maybe that's one of the reasons. Even, I have to say, even before I got to it, I thought, I'm still thinking, even in retirement, I actually can think. So, but the other thing was some of the other points that you made. So you talked about length of stay, and whether or not that, and it's always the whole idea, well, the longer they're in, the more susceptible they are. And so maybe talk about that a little bit more and sort of piece that out with what you found.
Yeah, I think the thing that was really interesting for us was that variable infection rate. And then when we looked, is there actually a benefit to doing the steroid? The children aren't necessarily leaving the hospital any faster. And so you're kind of having an increased risk of complications with a marginal clinical benefit. And so that's why we really wanted to think about what could be contributing to all of this. And I think the other interesting thing was secondarily, we have a really large group of children who had frontal advancements, and a lot of the voodoo and stuff that we as attendings and craniofacial surgeons worry might increase your risk of infection didn't actually show up when we looked at the statistics. I think hospital length of stay and I think length of duration of surgery were kind of the 2 things that might have played a role. And I think, amount of blood transfused, all the other variables we looked at, they didn't. And so it kind of changed how I thought about things. For us, I don't use steroid in front orbital advancements anymore. I think that increase in infection rate or the theoretical risk that could happen is not really worth it. I know in Seattle, they actually stopped using the gel foam technique once they saw the numbers as well. So it did have a profound impact on the practice of all of our institutions.
What's your sense, you know, a lot of surgeons around, craniofacial surgeons, what's your sense nationally about the use of it? Is it, you know, what's your feeling right now in 2024?
Yeah, so, you know, when I talk to people about it, I think there's some people that do a tumescent solution. I think there's some people that don't. I think the gel foam technique was relatively different than what a lot of people had been doing. And some of that had come about because there were some darker skin patients who actually wound up getting hypopigmentation of the skin from the steroid injection, which is a really terrible thing to have from something that's designed to just kind of smooth the recovery. And so that was a unique technique that was thought to avoid the injection into the skin. But I think in general, that's a technique that's not favored anymore. And I think in talking to other surgeons, it's relatively split. Some people do it, some people don't. I think the most people, almost everyone will do IV steroids, which there's some good evidence for from the Yale group. But I think it's something that's constantly evolving. I think we learn from all our studies and from talking to each other, and there's no right answer. I think that's the thing I love about craniofacial surgery.
Yeah, definitely. So Jessica, I just, you know, you're sort of new to this world, but I remember when kids used to have cranial vaults, they would be in the hospital forever. And the reason was we would wait until their eyes open. And it was really interesting to me to read this because I will tell you that years ago, I don't even know how many, we stopped waiting until the eyes open. We just sent the kids home. And we found, and you know, I didn't do a study on this, but I mean, I never had issues. I mean, they never really had issues. And, you know, I mean, some of the kids would be in for 3 more days, just sitting there, eating, drinking, jumping around, you know, pulling out stuff, you know, because their eyes weren't open. And so we just decided we're sending them home and, you know, watch them closely. And it's a couple of things. One, insurance is like you're keeping the kid in because the eye won't open, get out. You know, we're not covering it. You know, maybe it's stricter in New York, I don't know. But, and also the parents were just getting crazy because the kids were just going nuts, you know. And so I wondered, now this was, so when you first published this or when you first presented this, you would keep them at least until one eye was open. I read that. What's happening now? Because I know at least in NYU, we were just like, nope, you're going home. Let's just watch you closely.
Yeah, so in Seattle and Philadelphia, the criteria was at least one eye open. Everyone was really nervous about sending kids home if they couldn't open at least one eye and see something. Here, we do something similar. We make sure that at least one eye is opening before we send them home. And, you know, part of it, I think, for us is a lot of our patients are traveling 6 to 8 hours to come have surgery with us and just that reassurance that they're going to travel all the way home. I think if children were closer to home and families felt strongly, we'd be flexible about it.
Yeah. That's a good point. That's a really good point. I mean, we did have, I mean, a lot of our kids were local, but the ones that came from a distance would often stay in town until their first post-op visit. And so I think that too led to it. But I will tell you, it was hard in the beginning. There was a lot of resistance because of concern that, you know, are we doing the right thing? But no, that's interesting. When I read that, I just had so many memories about these parents going, "Get me out of here!" You know, I promise if there's a problem, I'm going to come back. You know, so interesting. So maybe talk a little bit about the limitations, which I thought was interesting in your case, Daniel, because, you know, you talked about when you do different institutions, you have different surgeons, but the fact that you worked in both places, and you really knew those surgeons and how they did the procedure, it made me feel that it was not as much of a problem for me to trust in your data. You know, what did you get that feedback from others as well?
Yeah, I think that, as you alluded to, having Dr. Cho, having been a part of and participated in working with these surgeons and doing these frontorbital advancements over the course of 6-7 years was a huge plus for us, because he could talk through the smallest details of each surgeon's technique, and we could postulate on whether that would have any clinical impact. But, from a statistical standpoint, we also included each surgeon and looked at that as a variable controlled for that to see if it really did impact our outcomes. And it didn't end up being something that impacted infectious rates at all. So I felt like it gave us this feeling of these results are more generalizable because we're including multiple institutions, multiple patients. We're not controlling for every little anesthetic component, every little postoperative component of postoperative care, but we also have this consistency that makes the data more reliable. So we have more faith in it from that standpoint.
I agree. And we knew from the start that that was going to be a criticism or a concern for people. And we did encounter it during our reviews. I think one of the reviewers was very much in favor. They understood that we had done everything we could to account for that. And then one of the other reviewers thought that that was a big problem. And once we kind of explained how we knew that the techniques were conserved, then it wasn't as big of a deal. And I think, in our field, we generally find that a lot of our studies are single institution. They're not reaching statistical significance. They're relatively small patient groups. And I think that's a big limitation in our field. And, if you look at Europe, they have a big network of all the craniofacial teams. They combine their data. They're able to really put powerful, meaningful data that can influence their practices together. And it's something that we feel really strongly about building in the US. The other thing that, moving to Wisconsin, Jess and I have realized is the majority of patients don't get their care at places like NYU or CHOP or Seattle. They get care at medium-sized centers, and that's a group that really hasn't been represented in our literature. So we actually don't know the true outcomes of the majority of kids that are getting craniofacial care in the country, and it's something that we're really working to try to address. And I think this is a study that really helped put that on our radar for us.
I think that's really something that, when you look, what can the ACPA do? I think we need to support doing more of that to really get a true view of what's happening with these patients. I didn't even think of that. That's a really, really great point. So what about the future? So I was going to ask you, well, what practice changes did you make? And you already said you stopped using you don't use steroids at all. Do you use IV after?
Yeah, we do IV steroids intraoperatively, and then we do a taper postoperatively, but we stopped doing the periorbital steroids just because that increased infection risk.
Right. So are you looking at your own patients prospectively?
Mm-hmm. Yeah, so we have our patients here, and generally we've found that the best way to get research done is to build a database of the patients, and so we built a database for our craniosynostosis patients here. We've actually changed some of our surgical techniques based on the data that we've seen in our patient population at our hospital. And that's kind of how Jess and I have driven our research program here, which is really exciting. But one of the other things that we're working on is there are a lot of younger craniofacial surgeons that have gotten to know each other in the Midwest. I think we represent a lot of medium and smaller size centers. And so hopefully over the course of the summer into next year, our goal is to create a collaboration of a lot of the centers in this area so we can pool our data and actually try to represent what patients are experiencing through our centers.
And that's the gold standard, right? I mean, it's to really get, multi-center, true numbers really reflecting what's happening. No, you're right. You're absolutely right. It is a challenge though. So lots of projects for you to do through your residency, Jess. I'm just thinking about you.
It's exciting. I've got plenty of time to do it and plenty of help too. We have a whole group here. Dr. Cho has his Cranie lab as well, which he established. So we have a whole workforce here, which has been really cool to see.
So let me ask you this before we wrap up is, so you're a relatively new researcher. And so a lot of people listening or watching are just embarking. And so I wonder, what advice do you have for newbies, in terms of, deciding what to study, how to do it, how do you balance it with residency? What are your thoughts?
That's a great question. I think the best way to balance it, just like anything else in life, you have to make time for it because it's always going to feel like there aren't enough hours in the day, no matter what stage you're at, especially in this field. But finding something you're passionate about and finding a mentor who you feel like you share similar goals and approaches with is a really good place to start. And if that's within your institution, more power to you. But if you can look outside of your institution as well, these days, a lot of people are really open to having other students onboarded and involved in their research. So, go online, look at what's being published and who you think has a reputation for being open to taking students on. I think that's one thing to think about. Another is just reading the literature. I know it's hard to make time for that sometimes, and also understanding it if you're a student or a junior resident can be hard, but the more exposure you have, the more you see how studies are done and appreciate the techniques, what things people are talking about, the better, the easier it is when you go to sit down and write something, and also the better quality your work is, and the more ideas you'll generate too.
No, great suggestions. Anything from the senior guy here?
Yeah, I think there's a lot to be learned from our patients. I think if you're taking care of patients and you see certain things come up or certain complications, or you feel like certain patients are doing better, I think it's really important to look into that. And that's how this project got inspired. I was like, I think these patients are doing better. And it turns out that anecdotally, yes, but when you run the numbers, it's not. And I think that's a lot of the problem in craniofacial and care and surgical care in general. There's a lot of anecdotal data and anecdotal stories, but when you look at the hard data, run the actual results, you're often surprised at the things that, we take for granted as being, dogma, are actually not really evidence-based. And that's, I think, a great lesson that we've learned from this project. And it's fun for me to have been able to take a project from residency through fellowship into attendinghood, get it published, and to have a paper with all of my mentors and our research fellow and resident. And for me, this paper kind of culminates my training. It's kind of like the dissertation from my training, and to be able to share it with all of my mentors has been really awesome.
Yeah, Jessica, I was just thinking that's quite a powerhouse that you worked with. So that's awesome for you to get, it's just a wonderful group. I've known so many of them personally. Rick Hopper was my fellow. We're very close. We have the same birthday. We are, still BFF. Yeah, and it's really interesting that now that he has moved to a different location, as everybody knows, everybody in Seattle is so sad. But he's now, in Austin, and he's now taking care of patients that I took care of who now live in Texas, and he may have taken care of them when he was a fellow. It just goes around, and it's just amazing. This community is really amazing, and that's why I'm really excited to see that you're thinking as young attendings in centers to really get together and really publish things that are important, that you have enough data that people will really believe it and trust in it. So that's awesome. I'm really glad to see that. So any last thoughts before I wind up and let people know about this paper that they must read? Any other thoughts?
No, I just want to say thank you for taking the time to talk to us and acknowledge the work. And it's been really lovely to be able to talk about it again too.
Well, I'm going to be looking for, future work from you. And as soon as I see it, I'm getting you back on. Daniel knows I'm a little relentless. I do go after people at ACPA meetings to try to get them to be on my podcast. So let me just read this paper again. And you can find it online first. It was posted, I think, March 28th. It's the 4th page of the online first papers. It might be in the, you gotta look there, you guys, to see, did it get into one of the current journals? But it is, for me, it's all the same now. It's all online. It's all amazing.
Yeah.
It's all there. So the paper is advancement, and the authors are Daniel Cho, Jessica Blum, Nicole Koenig, Jordan Swanson, Srinivas Susarla, Jesse Taylor, Rick Hopper, Scott Bartlett, and Craig Bergfield. And it's just amazing. Thank you so much. Really look forward to seeing you guys again soon. Thank you.
Awesome.
Thank you.
Thank you.